Thank you all for coming. My name's Matt Hoskins. I'm a psychiatrist from Cardiff, so I work for a crisis team with the general adult population. I'm also a clinical lecturer, so I teach undergraduate medical students about psychiatry, and I've been trained as a trauma psychotherapist. And I first got interested in psychedelic research when I came to the first Breaking Convention a couple of years ago, and I met Ben Sessa for the first time. And now I'm working with Ben, as well as my supervisors, Professor Jonathan Bisson and Professor Richard Wise, on a neuroimaging study looking at the acute effects of MDMA in patients with chronic treatment-resistant PTSD. So that's what I'll be talking to you about today. But to kind of explain why we're doing that study, I want to tell you a bit about what PTSD really is, what we know about it at the level of the brain, and then why MDMA seems like a substance that's ideally suited to assist in trauma psychotherapy. So I'll go through its kind of neurobiological effects and then talk about the study that we're planning, which is due to start early next year. So I've got no commercial conflicts of interest. Our study is part funded by both MAPS and Beckley, and we're incredibly grateful to them for their support. And if you want copies of the slides, they're all kind of annotated, and there's a reference list at the end, so you can email me if you want a copy of those slides. So first of all, PTSD, post-traumatic stress disorder, it's a very common, very serious and very severe mental illness that can affect absolutely anyone who's experienced one or more significantly horrifying or life-threatening events. So this is typically things like sexual assault, interpersonal violence, accidents, car crashes, or it could be combat trauma in our veteran population. And PTSD is really characterized by a cluster of around about four symptom clusters, really. So you've got re-experiencing symptoms. This is where you have intrusive recollections, nightmares that wake you from sleep, or even fully dissociative flashbacks of the traumatic event. So basically, the worst thing that's ever happened to you is constantly revisited on you for as long as you have the illness. The hyperarousal symptoms are related to kind of feeling keyed up and on edge, unable to relax, unable to sleep, unable to concentrate, easily startled, and constantly looking around for threat, basically. The negative cognitions are the kind of distorted thoughts that you have afterwards. So these would typically be things like feelings of guilt, of shame, of anger, and they can even be things like emotional numbing, where you're unable to feel the normal range of emotions, even normal attachment with your loved ones. Then you have avoidance symptoms. So this is when you avoid thinking and talking about the trauma. You also avoid any kind of environmental trigger. So if you've been in a car accident, you may no longer be able to drive, and you may not want to be around traffic or things such as that. So PTSD is a really, really horrible thing for patients to go through, and it causes significant distress, huge amounts of disability. More often people aren't able to carry on with their life or work as normal. There's huge comorbidities with things like depression and substance misuse, people using drugs and alcohol to kind of mask their symptoms. And unfortunately, suicide is the ultimate avoidant behavior. And you actually have the case where far more veterans die by their own hand after returning from combat than do in active combat, quite often related to the burden of PTSD. In the UK, the prevalence is between 8 and 9%, and if you go to conflict-affected areas, this can shoot up to a quarter of the population, basically, having this problem. And I won't go into the numbers, but it's very, very expensive for governments and societies to deal with on the whole. So there's a two-pronged approach for treating PTSD. The gold standard is the talking therapy, trauma-focused psychological therapies, and the two most prominent examples of that would be trauma-focused cognitive behavioral therapy with prolonged imaginal exposure, basically talking with the therapist and reliving the experience in a safe environment, and over the course of weeks, teasing out more and more kind of emotional and sensory information. And then there's EMDR, eye movement desensitization reprocessing, which works on the principle that kind of bilateral stimulation can help you kind of reprocess things. That's really the gold standard first-line treatment. There's some evidence. I had a paper published earlier in the year that found a small positive effect for just a handful of antidepressants. Sertraline should also be on that list. But these are really reserved for the second line of treatment or to add into talk and therapy, or while someone's languishing on a year-long waiting list, which is often the case. So with trauma-focused psychological therapies, the goal here is for people to confront their memories gradually over many, many sessions. And the aim is to help them feel less distressed when talking and thinking about the trauma at the end of the day. This terrible thing that's happened to them is never going to go away, but their symptoms may reduce and they may be able to kind of tolerate it. And then the kind of cognitive part of it is to do with challenging these illogical thoughts. Trauma-focused psychological therapies are effective for just over half of people, maybe up to kind of 2/3 of people, but not for everyone. There's very high rates of dropouts because it's a really difficult thing to go through. It's very, very hard work for people to actually engage in this therapy. They're either overwhelmed by the negative emotions or they're so emotionally numb that they can't engage with them. So we urgently need new treatment options, and we have a moral obligation to our patients to go down every route, basically. So if you were to design a drug to help assist trauma-focused psychological therapy, you may want to consider a substance that would help improve levels of arousal, motivation, and also relaxation. You'd want them to have a clear head for it not to make them kind of forget everything they've learned in the session. You'd want it to tickle the fear circuitry of the brain in a certain way. And it would be brilliant if it would do something to the therapeutic alliance, because that's quite often the most important part of psychological therapy. So have any of you heard of this drug before, MDMA, maybe? Okay, so you probably all heard of it. So it's a ring substitute for phenethylamine. It's got a very unique psychopharmacological profile. It was actually first used as a psychotherapeutic tool before being made illegal, and if you're caught with it in this country, you will get in a bit of trouble. We know the acute effects last over several hours, and it's characterized by this marked well-being, euphoria. You get kind of talkative, you feel very close to the people around you, and 9.9 times out of 10, you'll have a pretty good time, which is why they call it ecstasy. So just to review, there was this groundbreaking study by Michael Mitoffer and his colleagues in MAPS in 2010. It was the first double-blind RCT. So people had sessions of talk and therapy. Some were placebo-assisted, some were drug-assisted. And they found clinically and statistically significant drop in CAPS, which is the clinician-administered PTSD rating scale. It's the gold standard of assessing PTSD symptoms, and no drug-related adverse events. I presented this paper to one of my Friday kind of teaching groups and invited my now supervisor, John Bisson, along, and that's how I kind of got involved in the study in Cardiff. And the most striking thing is really this graph. You can see this precipitous drop in CAPS after the very first session in the graph on the left there. Then there was the follow-up data in 2013, which showed that subjects maintained this clinically and statistically significant gain in symptom improvements. Unfortunately, 2 patients did relapse, but this does happen with standard, trauma-focused psychological therapies as well. And again, no subjects reported harm in the longer term. There was another paper by Peter Otten, which did show a showed a clinically and statistically significant self-reported improvement in symptoms, and there was an effect size similar to the Mitoffer paper, but the overall effects may not have been statistically significant. It was in line with the Mitoffer paper. It did show that 3 MDMA sessions were more effective than 2, and this was a very, very small study. Okay, so just to review the neurocircuitry of PTSD, we know that there are structural and functional abnormalities in brain regions that are associated with fear conditioning, fear extinction, and emotional regulation. So I'll kind of run through some of these. So the amygdala and the insula, these are structures involved in threat detection, and the insula kind of marks fearful information for higher processing. We know that they are hyperactive in response to trauma symptom provocation. So if someone has to read maybe a narrative script of their trauma, or they listen to an audio recording of them talking about their trauma. Not only that, they're hyperactive in response to non-trauma related emotional stimuli, so maybe looking at angry faces and things like this. We know there's a positive correlation between this activation and the overall severity of PTSD symptoms, and that is reversed with successful exposure therapy. Then you've got the anterior cingulate cortex, medial prefrontal cortex. These really are concerned with cognitive control over emotional responses, basically. They're kind of like the brakes on the amygdala and the insula. So they are reduced, there's reduced activity in response to trauma symptom and non-trauma related stimuli. And there's a negative correlation between their kind of deactivation and PTSD symptom severity. So it's kind of the opposite picture of the amygdala and the insula. And again, successful exposure therapy reverses that, so it brings it back down to normal. Then you've got the hippocampus. So this is a structure involved with like forming memories. And we know that there are problems with memory in PTSD because people have these intrusive recollections and flashbacks. The hippocampus in PTSD kind of modulates memories according to context. And there are discrepancies in what the hippocampus is really doing in PTSD, but the most recent meta-analysis suggests that overall there's probably reduced activity. In particular, it's kind of reduced in response to trauma scripts. And again, in a study that looked at subthreshold PTSD, when this is treated, that reverses the hippocampus underactivity. And then finally, about the brain changes in PTSD, you've got something called the resting state functional connectivity. So when your brain isn't doing anything at all, certain areas seem to be synchronized with each other, and these areas appear to be altered in PTSD. So there's increased connectivity between the amygdala and insula. They're very close together. There's reduced activity then between the amygdala and the hippocampus. And then there's negative correlations between the amygdala, the medial prefrontal cortex. And overall, this kind of supports the hypothesis that there's an inhibitory role of the front of the brain, the prefrontal cortex, and the amygdala. So the amygdala is overactive, the prefrontal cortex isn't really doing its job and allowing the amygdala to remain overactive. We know that MDMA in healthy controls produces a euphoric effect, and the magnitude of that euphoric effect is correlated with reduction in blood flow to the amygdala. And the amygdala's response to fearful faces is also reduced. And overall, this again suggests that MDMA may exert some of its therapeutic effect by decreasing the coupling between the medial prefrontal cortex and other areas. So going back to MDMA, we know it's got a very unique psychopharmacological profile. It exerts its main effect through serotonin, and then to a lesser extent, also dopamine, noradrenaline, cortisol, and it has some alpha-2 activity as well. And then it also has this rapid, robust release of oxytocin, or the love hormone. So the next few slides are some of Ben Sessa's, which are excellent, looking at all the different kind of receptors and what they do. So through serotonin or 5-HT, 1A and B, you've got decreased anxiety and depression. 2A is the psychedelic change in perception and giving new insights with the serotonin effect. The stimulation that you get, the kind of arousal and motivation, mostly comes through dopamine, noradrenaline, and cortisol. And then this paradoxical relaxation comes through the alpha-2 activity. Because to engage properly in trauma-focused psychological therapy, you need to be in the optimal window of arousal. So the stimulation part brings you up, and the alpha-2 part brings you down, so you're in that right place to engage in therapy. And then the oxytocin, the love hormone, why people get so huggy. This is all due to oxytocin, and this is why MDMA is really called an empathogen as well. So on the surface of things, MDMA seems ideally suited to trauma-focused psychological therapy. You get a positive mood with creative thinking, which could lead to new insights on all problems. The stimulation and the paradoxical relaxation gets you into that optimal window of arousal. And then the empathy and bonding helps you to connect with your therapist. And this is incredibly important. So we know that oxytocin, or the love hormone, enhances the quality of pro-social interaction. It can facilitate the faster detection of happy faces when people are faced with a series of images. And it reduces the detection of negative faces in MDMA versus placebo. And in one study, there was greater improvements in pro-social communication in patients who had MDMA versus intranasal oxytocin, which is the argument really against why don't we just use intranasal oxytocin. And it's really because of the more robust dump that you get from MDMA, and also because of the cocktail of effects that you get from MDMA. We know that emotional numbing can be a characteristic feature of post-traumatic stress disorder, and that in any modality of psychotherapy, there's a strong link between the strength of the therapeutic alliance and a positive therapeutic outcome, whether you're doing psychodynamic or CBT. One of the most important things is the bonds, the relationship that you form with your therapist. So MDMA induces this very large release of oxytocin, and the magnitude of the pro-social feelings is strongly correlated with the amount of oxytocin that MDMA causes to release. The amygdala is required for accurate social judgments, and oxytocin markedly dampens fear-related amygdala activity, decreasing the stress response and decreasing social anxiety. And healthy controls who were given MDMA were better able to detect positive facial expressions and responded less negatively to angry faces. And in healthy controls, MDMA increased medial prefrontal cortex activation and decreased amygdala activation in response to angry faces. So this is just in healthy controls so far. MDMA is not without risks. You know, as a clinician, you prescribe lots of different drugs, and they can have benefits and they can have harms, and you have to be very open and honest with your patients about that. And when you decide to give someone maybe olanzapine or quetiapine, you're really weighing up the benefits and risks of being on that drug. So the risks associated with MDMA are related to hyponatremia, when you've got very low blood salt, hypothermia, which is much more of a problem if you're in a confined lecture room like this maybe, or maybe like a busy club and you're dancing. And then you get the kind of gurning, this orobuccal dystonia. And then rarely you can have serotonin syndrome, which is when you've got overstimulation of your serotonergic system. So far, most research on MDMA has really focused on recreational ecstasy, which we know is not related to clinical MDMA. And a lot of these studies have been quite flawed. We know that recreational use doesn't mirror controlled clinical use that we propose. In animal models where they've seen you get serotonergic system burnouts, they give repeated gigantic doses, you know, day after day after day, and of course, you know, that could happen. But this isn't generalizable even to someone who's like, you know, boshing 5 pills a day or something like that. So neurotoxic effects aren't seen in humans in equivalent doses. We're all probably aware of this study from David Nutt looking at the 20 most commonly used and abused drugs, with MDMA here ranking 18 out of 20. So the good news at the end of all this, we've secured $200,000 in funding from various sources, including MAPS and Beckley, to explore the effects of how MDMA could help people with PTSD, which is great. So we're working with Cardiff University as well. Our study design, it's a randomized, double-blind, placebo-controlled crossover fMRI with 2 experimental conditions. We'll be using a full dose of MDMA, 125 milligrams, versus an identical inactive placebo. And this is a schematic of how the study will look. Everyone will be enrolled, have all their baseline tests. Then they'll be split into 2 groups. Half of them will receive MDMA first, and the other half will have it second. But everyone will have 2 brain scans, and everyone will have both MDMA and placebo. We'll be preparing patients with 4 90-minute sessions beforehand. They'll be allocated to either myself or to Ben. Everyone will have to come off all of their psychotropic medications pretty much everything will have to be reduced and stopped because it could either interact with MDMA or reduce its effect. And this isn't a treatment study. We're not actually offering an intervention. This is just a mechanistic study. So we have to wash everyone out before they can actually have their scans. The experimental sessions will take place first thing in the morning. So they'll arrive maybe about 9 o'clock. They'll have their MDMA or placebo capsule in a kind of a pre and post scan comfortable room. So this is where they'll kind of come up, and this is where they'll come down after the scan. We'll have a female co-sitter present as well. So Ben or I will be present with every patient, and we'll have a female co-sitter there just because of the nature of the novel experience and following from MAP's advice. Once they've had about 60 minutes to come up off the effect of the drug, they will go into the scanning suite. They'll be in the fMRI scanner for 60 minutes, undergoing a couple of different tasks. And then we'll bring them back out into the post-scan room. They'll complete one measure of emotional and cognitive empathy called the MET. And then we will sit with them and allow them to be with the experience until they're assessed as safe enough to go home with a significant other. And then they'll have lots of telephone contact and personal contact in between scans and afterwards. So our hypothesis, we think that their subjective units of distress, or their SUDS, will be lower in the MDMA group when they're having their symptoms provoked. And we think this will correlate with decreased amygdala activation and increased medial prefrontal cortex activation. So the changes you see in PTSD will be reversed. In response to fearful faces as well, we think that the amygdala activation blood flow will be reversed. And the resting state functional connectivity changes that you see in PTSD will also be reversed with increases in cognitive and emotional empathy. So we hope that the results from this study will add to the understanding of how MDMA could assist our patients with chronic resistant PTSD and hopefully lay the groundwork for future phase 3 randomized controlled trials. Many thanks. Any questions?